It now gives me enormous pleasure to welcome Professor Rummel here today and to thank him very much, because this is his second trip out to Australia in less than 6 months to talk with us about the very important impact that Bendamustine, the new old drug, is going to be having on the management of many of our patients with lymphoma. Professor Rummel, thank you very much for coming today.
So thank you very much for invitation. And when I was asked, I was very happy, as Judith mentioned, to travel again to Australia. And then when I opened the agenda, I found that the people here gave me a very funny title: Bendamustine, best thing since sliced bread. So you have to really understand what does it mean, because when you travel you understand that these wordings mean different in different countries of the world. So I was looking into the internet and I found the explanation. So advertisement from 1943, how important sliced bread is to the moral and saneness of a household. And then they say the greatest thing since sliced bread is commonly used of praising an invention or development. And somebody wrote, it's the ultimate depiction of an innovative achievement and American know-how. So in Germany, when somebody would say sliced bread, we would say that's something simple, another sliced bread, nothing very special, don't pay attention, it's just sliced bread. So therefore it's interesting to know, and I would like to focus on that title and to explain to you the role of Bendamustine, which I was asked to discuss. Bendamustine was developed more than 50 years ago. Yes, Judith already said it's a rebirth of an old drug. It is active as a treatment in different diseases. In non-Hodgkin's lymphoma, as well in Hodgkin's disease, in myeloma, in chronic lymphocytic leukemia, and also it has shown some activity in breast cancer and small cell lung cancer. So it was developed 50 years ago, so it's a very old drug in east part of Germany, which was a communistic part of Germany. So the reason why in West Germany nobody had any knowledge about the Bendamustine, which was used in East Germany, because that was the iron curtain between the two countries in these days. After the reunification, we learned that Bendamustine comes out of East Germany, and the colleagues from East Germany, they told us, use Bendamustine, it's brilliant. And we were thinking, oh, it's as good as sliced bread. That means nothing new. Why should we use it? And of course, it was an emotional feeling. East Germany, communistic, cannot be good. That was a moment in that situation. And so after 10 years, by using it occasionally, yes, we learned, oh, Bendamustine really is active, and maybe we should investigate it. As Professor Zilsal said, we need to make a study to compare it to the standard treatment. I was learning in Frankfurt medicine, in these days, we used CVP or CHOP for the treatment of indolent and follicular lymphoma, both. When I was a young doctor, I kept on asking my professor, why using this time this and the other time that? CHOP and CVP. CHOP is a good treatment, and he told me CHOP is curing the aggressive lymphoma, however, does not cure the follicular and low-grade lymphoma. From that time on, we wanted to do a question. Why do we need to treat patients with CHOP? Because it has its toxicity. Maybe we can not use CHOP and maybe only CVP or a different treatment. And so that was how the story with Bendamustine began, because we started to use it within a clinical trial. And that was the first time ever that Bendamustine was investigated, because it came from Germany. It only was approved and available in Germany, and that is the reason why we started a study. And I would like to lead you through and then allow some question, and that is how we do that study. R stands for randomization, so by chance patients with that kind of disease were selected to have that treatment or that treatment. That is a standard, so no big discussion about that, and that is the so-called experimental arm. And we included patients with this kind of lymphoma disease, follicular, Waldenström, marginal zone, small lymphocytic, and some very elderly patient with mantle cell lymphoma. That was the plan of the study. We planned to do 250 patients in order to get some hint if that makes sense to treat with the one or the other. But the study was going very fast. Why? Because German doctors feel really provoked by that study. There were many doctors believing that is not meaningful. We have to use CHOP. Therefore, because they believed in CHOP, they participated in the study. The other one said, no, we need something else beyond CHOP, and therefore I feel motivated to participate in the study. In the end, we had 500 patients, 549 between 2003 and 2008. And it was a well-done study. It was done on our own initiative. It was not run by pharmaceutical companies. And we have presented that trial very often. And then in 2013, 10 years later, we started that study. In 2003, we were able to publish that in a journal. So nowadays, everybody can read the results of the study. And I would like to show you what we found. So when we first do that studies, we show always the two treatment arms. If it's balanced between, it should be balanced because it's selected by chance. And therefore, the patient with the age, the kind of disease, and the body weight, and other disease characteristics really should be balanced. And here you see we had 421 patients with a so-called indolent low-grade lymphomas, and 93 patients with a mantle cell, and the age of the patient was 64. Very typical age for that kind of disease. And here are the side effects and the toxicities. And you see here that we count how much is the blood cells impressed and depressed by the treatment. You know, when you give chemotherapy, leukocytes or platelets going down in a transient time for 1-2 weeks until they recover, and that is always a time for risk of infection and does not allow to continue with the next cycle because the blood needs to recover. And here we can measure it. We call it grade 3 and 4. That is very deep of going down the leukocytes and giving more risk for infections and complications. And this was much less often the case in the patient treated with bendamustine. It was 12% on 10%, and here it was 38%. So it happened with CHOP more often than with bendamustine. That is a good symptom that you see less toxicity in respect of the blood cells. Then we looked for organ toxicity, and the one major difference was that you do not have any hair loss. And with CHOP-R, most patients have some kind of hair loss. Of course, maybe that is not the most relevant thing as a side effect because the hair will grow again after the treatment, but still it's a very emotional moment for the patient when he has to accept the fact that he will have no hairs for the next weeks and months. So yes, if you would like to have the choice, probably you would say if everything is the same, maybe I would prefer the one treatment which does not make hair loss. And then we have some other side effects. This is neuropathy. Some patients feel these tingling disturbances in the fingertips or at the toes of the feet. And that happens with CHOP, not in every patient, but in some patients. But it's a fearful side effect. And with bendamustine, that happened less often. 18 patients experienced that kind of toxicity out of 260, and here it was 70 patients out of 260. So yes, it happened less often. What we saw more often with bendamustine was some kind of skin irritation. So it was erythema, red skin, some pruritus, some allergic reactions, and that was seen in 82 patients and only in 43 with a CHOP regimen. And then we saw less infections, 96 in the one arm and 127 in the other arm. So the message out of that slide is, yes, the treatment has side effects. Also, bendamustine has 96 patients with an infection. So it's not just like sliced bread. It is a clear chemotherapy. It has its side effects. It can be dangerous. But as a comparison to the standard, it was a little bit less for the patient to tolerate side effects. So now we have investigated the side effects, and then we come to the efficacy. First, you see the response rates. This is here the abbreviation for overall response rate or for complete responses. That is not a very meaningful criteria, but it's easy. You just can have a look after the treatment if you have success or not. If the lymph nodes are gone, if you don't feel them anymore, if you don't measure them in a CT scan, yes, that's a good success of the treatment. But of course, the more important success would be if the treatment stays away for a very long time. Not just the response after the treatment, but it's very easy, therefore we compare it. And you see here, 92.7, 91.3, more or less the same. There's no difference. That is, of course, a very small difference which is not meaningful. And then we looked for the disease control, and then we present always this curve. If that curve is more higher, that means always when a curve goes down, some patient has an event, so some relapse occurred of the disease. So that happened slowly and a little bit less often with the bendamustine arm than with the CHOP arm. So that was a major result. Bendamustine was not only less toxic, but also has its good efficacy even on a long-term result. So that was then published in the journal, which everybody could read. And we have then looked for the different diseases because, as you remember, we have included different diseases. But clearly, this is only the low-grade lymphoma disease, not the aggressive lymphoma disease. So that comparison only is true and only can be used for patients with a low-grade lymphoma. So we have here the follicular, the nodal marginal zone, patient with mantle cell lymphoma with a higher age, and patient with a Waldenström disease. And always there is a clear trend that the bendamustine rituximab has a longer disease control than the standard comparator CHOP. And then we have looked with a very long update, and you see here that we make observation of the patients until 120 months, that is 10 years. Most patients can be followed more than 5 years. And here we just describe how many patients needed a second treatment because the disease came back. And this clearly shows that when you understand this curve, 50% of the patients did not need a second-line treatment. So the curve here makes you the statement. 52% did not have a second-line treatment after 100 or 120 months, or 48% had needed a second-line treatment. And with CHOP-R, it was a little bit more often than patients needed already a second-line treatment. So that is the message. Bendamustine rituximab was given to the patients with low-grade lymphoma. It was less toxic with side effects, but it has clear toxicity. And in the end, it controlled the disease for a longer period of time. Also, we want to see, and that is, of course, the most important thing, if that also is valid for the survival prognosis. And of course, some patients don't want to ask, but of course everybody is thinking about that. And so they also, some patients ask me clearly, what is the chance that I'm still alive? And always that question is very complex to the doctor because we are not able to say you a number or a percentage, but we can say when we are very precise, in one clinical trial, in this investigated patient group, there was a chance of survival of about some percentage after 10 years. And that is here, this survival curve, and that gives you some idea what happened in that trial. Not necessarily that is true for every patient in the future, because every patient has its own disease and its own destiny, but this is a statistical assumption. And it says that with a 71% probability, patients are alive after 10 years. And that also gives us some feeling if that disease can be controlled with that kind of first-line treatment or second-line treatment over a long period, or if maybe, as Professor Salz had mentioned, some strategy is not good because in the first moment you have a good treatment, but in the end it's a disaster because you have so many long-term side effects, and in the end you don't have a good long-term outcome. So therefore we need to observe in clinical trials for a long time our patients. So we concluded, and we have discussed it with many pro and contras. Bendamustine rituximab was in that one study associated with a smaller toxicity. It has, I have not shown you, but this was already discussed in some scientific meetings, no late side effects like another secondary cancer. It did have a prolonged disease control, a prolonged time to the next treatment, and also there is some hint and some trend that patient may survive a little bit longer, but this is of course not very clear. And therefore it was concluded in many meetings, bendamustine rituximab is a good treatment, and this really is a new treatment for many parts of the world and can of course enforce the armamentarium of the available treatments. I would like to show you how the international community thinks about it. Interestingly, we have this Nccn Guidelines. This is written by some American experts, and they always give a recommendation what to use in which kind of the disease. This is available for doctors, also if you look in it for patients, if you get access to it. And this is summarizing all knowledge. And here you see they make different recommendations. They give first-line recommendation, first-line for elderly or infirm, and second-line recommendations, and so on. Not necessarily you have to believe that this is the truth, but it's a summary of a consensus of experts, mainly from America. You see here that bendamustine rituximab was one of the first-line recommendations with R-CHOP, RCVP, fludarabine, radioimmunotherapy. Professor Salz has mentioned the one with a radioactive isotope, and rituximab. 2011. In 2014, the first-line treatments were a little bit smaller. Only 4 treatments were recommended. Radioimmunotherapy is out. As Jill Sal mentioned, he has not used it in the last 5 years. In Germany, 80 patients were treated in the last year, which is nearly as nothing, very, very small group of patients only. And also in my clinic, I have not used it, the radioactive isotope conjugated with the antibody. But we have to pay attention in these guidelines. This is alphabetical order. It does not mean that the one or the other treatment is better. But interestingly, and that I learned just some weeks ago, the new version 2015 shows the same picture, but lenalidomide, which Professor Sal has mentioned, with a long trial ongoing worldwide, has made it to the first-line recommendation, but now they make it in preference order. So the field moves, and the field tries to adapt according to the knowledge we learn and to the matureness of the results. And so it's interesting that these things continue. Coming back to sliced bread. This is 1930, and what was the conclusion of sliced bread? People ate more slices of bread at a time and ate bread more frequently because it was so easy to eat another piece of bread. And also the consumption of some jam put on the bread increased. So with that, I would like to say, no, don't use it like sliced bread. And it is not so easy to make a statement on that question if it's the best thing than sliced bread. Yes, you have to say, Bendamustine, it has strength and weakness as all other treatments. It has its toxicity. It was rather better acceptable in that one trial comparing to the other treatment. It has good efficacy, however. Again, it's a little bit disappointed that it cannot cure that kind of disease. But this is with a question mark. This is what I would like to say. However, when you see that curve after 10 years, you see still many patients without in any second-line treatment still under control of the disease. So we don't know if maybe these patients still are in ongoing remission after 15 years, and we have once to debate when do we call them cured. And so far we don't use that word because we have learned a low-grade lymphoma cannot be cured, but maybe in the end when we make another update of such a trial, we see still patients are in ongoing first response after 15 years. And it provides with a high probability long-term outcomes, but potentially, I would say, it can make the treatment easier, but it should not be used like sliced bread. That means it's not just a simple thing, what you can use as your daily consumption. You have to be very cautious, and when the doctor decides to have that treatment, it has some pro and contra, but out of that study, it is certainly something new for patients with that disease. With that, I would like to thank you for your attention, and maybe we have some questions to discuss. So the question was, how does it compare to RCVP? The answer is that we cannot make all these studies with all comparators we would wish to do. And so sometimes you make some speculation if that can be used, that treatment results out of that trial for the comparison of CVP. And of course it cannot directly one-to-one give you an answer for that question. CVP has less toxicity because it has only 3 compounds instead of 4, and the one is a very aggressive one, the anthracycline, doxorubicin. So CVP has maybe the same grade of neuropathy, but less damage to the blood and maybe less cardiotoxicity potentially and so on. And on the other hand, it has a little bit less efficacy than CHOP. So you only can speculate. Probably CHOP is a little bit better than CVP, and if that comparison holds true to CHOP, probably it holds true to CVP. That is our assumption.
Who's got the microphone?
Talking about RCVP, I was on that 3 years ago. I had multiple lymphoma. I'm on one of the studies in Australia, very first one recently, on the rituximab and Bendamustine. My question is, I'm halfway through it, it's not working, so what do we do now, or when does it start to work? Would it kick in halfway through, or what? Because my hematologist doesn't know what to do at the moment.
Yes, so the clinical trials, as I have presented, have much more information in detail, what we discuss when we are on meetings or when we make the publication. So one of the questions is, how fast does it work? Do one necessarily to go through 6 cycles? So clearly that is not the case. You have to decide much earlier, because if you see that the treatment is not working, you should not continue, because then you have for clearly side effects but no efficacy. And so you see the response rate was 92%. at least 8% had nothing from the treatment, even directly after the treatment. So our recommendation at the time now is after 2 or 3 cycles, you have to look if the disease has responded in a good way to the treatment. If yes, continue. If no, make another plan. But what kind of plan has to be given, I cannot answer at that moment because I don't know the history and so on. But that is the message. If it does not work after 2 or 3 cycles, stop it. Also, you have to stop it if it is not tolerated by the one patient because of side effects.
One last question. Who's got the microphone? The gentleman in blue. Thank you very much.
Thank you. I was wondering with the Bendamustine, whether there is an optimal time at which to introduce it in a treatment protocol. Currently, I'm in a watch and wait protocol, and wondering at what point in time would be judicious to introduce that.
So you have to really look very precisely to such trials. That trial did not answer the question if a watch and wait period can be shortened or not, or even be longer. Nothing to do with that question. It was just simply patient in need of treatment comparing 2 different regimens. And the current knowledge and the current consensus on watch and wait is, as long as possible, one can do that period, one should do it if you feel well and don't have serious symptoms. That is a consensus more or less around all countries of the world.
Absolutely, absolutely. Perhaps I could just finish with one extra little comment for sort of all Australians with low-grade lymphomas, in particular those with follicular lymphoma. And come back to something that Professor Saal mentioned earlier about the importance of the biopsy. All right, and the anatomical definition of the lymphoma and the characterization. There are 3 different grades of follicular lymphoma, grade 1, 2 and 3. And my understanding, Professor Rummel, your study, the follicular lymphoma patients were just grade 1s and grade 2s, wasn't it? So, it's an important thing to point out and, take-home message that every patient is unique and clinical trials have very specific criteria for eligibility, and we have to be a little bit cautious at taking home and applying exactly to ourselves all the general messages that we are given here today. But certainly we in Australia, as everywhere around the world, are very excited about the capacity to offer Bendamustine in the treatment armamentarium for our patients with low-grade lymphoma, and our fingers are crossed that the PBS will feel likewise as excited by Professor Rummel's data as we are. Thank you very much indeed.